How are we doing now?
A little more.
Still no. There we go.
That's better.
So my name's Scott Hall, and I'm tag team with Robb on this presentation. These guys are getting it set up, but we're going to talk a little bit about a program that we started in Reno, Nevada, and working with our local law enforcement population. There's a reason why we did that. I work, my background is as a physician, and I work with police and fire fighters throughout our community and actually throughout the state of Nevada. And we noticed, how are we doing? We got it? There we go. Good. We got it. Cool. Okay. So we worked with our local police and fire, and this is an introductory slide. I think you understand these principles. I'm going to move quickly because these guys tell me we're running a little behind time. These are some traditional cardiovascular risk factors. I'm sure most of you are familiar with these. Why did we pick law enforcement? Law enforcement in our state and in most states throughout the United States, they receive an annual physical examination where they sit down, get a very comprehensive physical exam, laboratory evaluation, they go through a stress test, and so we can identify, these guys are identified and their cardiovascular risk factors are known. And one of the things that we have found is that these guys, where's my pediatric dentist from Chicago mentioned that his population was pretty sick. These guys are pretty bad, and I'm going to show you that we found that they have a very high incidence of cardiovascular risk factors. One of the things that we also know is that they have some occupation-specific risk factors. They include the option that they may have to go from a completely sedentary activity to a full physical exertion at a moment's notice, and that can be unpredictable. We also know that they face chronic stress from their work, and in our community, our police work in a traditional shift work environment, meaning there's a day shift, there's a swing shift, there's a graveyard shift, and that changes about every 3 months. And so their sleep cycle can get out of balance. And we know that other authors have noted that wellness programs can be particularly effective in this population. This is a recent study that looked at and compared certain cardiovascular disease risk factors between a general population and a law enforcement population, and you can see some of the differences in cardiovascular risk between law enforcement and the rest of us. One of the epidemiologic studies that was done very recently was done in the state of Florida, and this compared the life expectancy of the general population in the state of Florida versus a law enforcement population. They found that law enforcement and correctional officers didn't live very long. They lived about 62 years as compared to 74 years for the general population, and we think that's largely due to the fact that they have increased incidence of cardiovascular disease. This is simply a graphic representation of that epidemiologic study. You can see that their curve is shifted to the left. They're dying at a younger age. This is from the American Heart Association, and this is just simply one statement. If you look at a number of the national governing bodies, they all support wellness programs in a workplace environment as driven by an employer. So with that as a background, one of the cool things that happened in Reno is that I've been working with law enforcement and fire for a long time, and we figured out fairly early that the traditional American Heart Association diet we weren't getting the kind of results that we expected to get, and that led us to look further at the nutritional component. And a couple of years ago, we caught a lucky break, and Robb moved to Reno. Robb, when was that? Was that what, 2008? 2011. So he moves to Reno when we're kind of getting into this, and it allowed us to collaborate. with a couple of different people. One of the very fortunate things that happen in our community is we have a very progressive police chief, and we met with him, and he's very concerned about the health of his employees and his officers. And my partner and I met with him. We lobbied the city council and our mayor, and we got a grant to put through a small group of police officers through a program. And these are some of the results. Now, we got a small grant to do this. 15 officers were chosen. Now, I say chosen because one of the things we found when we've gone into to meet with employers and implement wellness programs is that what typically happens is that we get the worried well. We get many of the people into the program who voluntarily want to go into the program, and we don't get the people that we really want to bring into the program who have a lot of cardiovascular disease risk. So these 15 officers were chosen by police leadership because the police leadership knew based on their annual physicals that these guys were at very high risk. So according to ATP3 guidelines, and for those of you who don't know what that is, it's simply guidelines that are followed by primary care physicians and cardiologists throughout the United States, and a way of estimating cardiovascular disease risk. These 15 officers were all either high or moderate risk for cardiovascular disease. What we did is we brought them in, we did some initial biometrics, we did a laboratory assessment. This included a lipoprofile, and I'll show you what that is. And then we graphically represented it by a big 5 chart, and I'll show you what that is here. This is one of those officers. This was the youngest one of these officers. You can see the date on the top, or maybe you can't, but it was February 1st, 2011. And he's a 33-year-old young man. And the red, green, and yellow means exactly what you think it means. Red's bad, green is good, yellow's in the middle. We do a risk assessment, and we use some tools that physicians throughout the United States should be using. A Framingham risk assessment, that's a 10-year estimate of cardiovascular disease risk. And then we also look very heavily at metabolic syndrome. And then also we use a triglyceride to HDL ratio. The reason we include a triglyceride to HDL ratio with metabolic syndrome is we believe that those are strong markers of insulin resistance. This is a lipoprofile, and just focus on one number, and that's this number up here, LDLP. LDL particle number is what that is, and when physicians throughout the United States traditionally measure cholesterol, they measure a cholesterol concentration called LDL-C, and you can see that number below the number I've highlighted. However, when you get insulin resistance and some other things, their actual cardiovascular disease risk more closely follows their LDLP, or their LDL particle number. And I'll explain a little bit more about that as we go on. I just wanted to give you an idea about what that is. This is the second page of the lipoprofile. We know that insulin influences cholesterol, and by running a lipoprofile, you can infer how sensitive or how resistant a particular individual is to the hormone insulin, and it gives you a numerical score at the bottom of this page, which you see there. And in general, you can see 100 is the highest insulin resistance score, 0 would be the lowest, and obviously the lower the better from our perspective. So once we had done the initial evaluation on these folks, they all sat down with me, had a physician evaluation. They were informed about their risk factors, and then they met with an exercise physiologist who works with us, and they met with a registered dietitian. Usually when I say registered dietitian, one of the challenges we've had is, and I've heard it mentioned in some of the other places, is many times when we get a registered dietitian, that person is going to talk the American Heart Association diet, which we think is wrong in many ways. So our dietitian is a paleo dietitian. He's a guy who speaks our language. And so he gave them a paleo low-carb diet that they were to follow. We followed these guys up. between 4 to 6 months, and the intervention was simply fitness, nutrition using a paleo approach, and basically our nutritionists and exercise physiologists followed these guys or provided some health coaching throughout that period. The average age of these participants was 45 years old. I showed you the youngest member. Most of these guys, we had one gal. Most of these guys were in their 40s and 50s. So that's the population we're talking about. These results were published in the highly academic journal Police Chief Magazine. This is December of 2012. So our police chief published these results in this magazine. And one of the key things that he focused on is return on investment, meaning we got a small grant, and what kind of financial impact will this have? And this is the kind of information that city councils and mayors want to know. But essentially, if you look at, if we were to implement a wellness program like this, and based on our results, if we were to continue this wellness program for the next 20 years, the return on investment was 20 to 1. Meaning for every $1 that you spent, you saved $20. This is some biometrics, and what you're going to see here are just simply the initial results, the after results, and then down below is the difference between those two. So blood pressure, weight, body mass index. Just a word about body mass index. We don't think that's the best measure. What we're really concerned about is body fat, but it's one way, it's one standard way we have of looking at body composition. Next, so these are cholesterol results, and you can see LDL-P on the far left. LDL-C is next to that, HDL, triglycerides, and total cholesterol. One of the things that you'll notice and that's striking is the reduction that was observed in triglycerides and the increase in HDL cholesterol. One of the things that physicians like me often struggle with is trying to treat individuals who have low HDL levels. And we have simply found, and has been reported in other places in literature, the best single way to do that is with a low carbohydrate diet. These are some insulin resistance markers that were observed during the study. I mentioned the triglyceride to HDL ratio and how that number improved, and then also the calculated insulin resistance score improved as well. Additionally, we saw a reduction in their blood sugar. That's a fasting blood sugar. I'll talk just a little bit about lipoproteins just to give you an introduction. One of the things that we know now is that LDL-C is not the best measure of cholesterol in predicting future cardiovascular disease risk. These are some authors who we've met with and agree with, and I'm going to show you this slide because this gives you an example of how cholesterol is trafficked in the bloodstream. Each of these spheres represents a lipoprotein and is important in your metabolism. And inside each of those spheres are cholesterol and triglycerides. One of the things that a concept that I hope to at least introduce to you is why we think lipoproteins are important. You can see this is a lipoprotein. It contains some signaling proteins on the outside called apolipoproteins, and the inside are the triglycerides and cholesterol. And it's these lipoproteins that essentially cause atherosclerosis. And one of the things that is emerging research is demonstrating is that it's not just the cholesterol concentration, it's how many of the lipoproteins there are. And so an analogy we'll often use is that a lipoprotein is like a car on the freeway. And inside that car are a number of passengers, and those passengers represent cholesterol. And when you're driving down the freeway, it's not how many people are inside the cars that you're concerned about, it's the number of cars on the freeway. So in essence, we've developed a term, it's not the passengers, it's the cars, meaning LDL-C can be misleading. Some of you have probably had cholesterol tests by physicians who have looked at your cholesterol on a paleo diet and said, this is crazy. your LDL-C is too high. But one of the things that we know is that lipoproteins, which is a much better predictor of cardiovascular disease risk, in most people substantially decrease on a paleo low-carb diet. This you'll recognize. This is the young man that I presented earlier. He's 33 years old. He's in deep trouble. He had a family history. His father suffered a heart attack in his late 40s, and this guy was on the same road. This is him today, essentially. I mean, this is about 4 months after it, but I'll tell you that he's stuck with the plan, and this is him today. And the results were really, really nice. He's our star patient. I mean, so don't think that this happens to everybody, but this can happen. And this is his lipoproteins. They've gone from over 2,000 down to around 1,000, which is our goal. His insulin sensitivity has significantly improved, and it will continue to improve as he sticks with the right lifestyle. This is him, and this is just simply before and after in a graphic representation. The other question I get asked frequently is, can we sustain these results? And I'm going to just show you 2 other officers that we've worked with both the last few years that I think demonstrate that. This is a really cool guy. You can see he was 31 years old. The date up on the top is 2002. He was one of our first patients in the program. And one of the things that you may think when you look at the slide is this guy wasn't exercising. He had run a marathon a month before this test was done. And you may be surprised when we look at aerobic capacity. So when we do a stress test, we get an estimate of aerobic capacity. And why is his aerobic capacity low? We asked that same question to him. If you just ran a marathon, why is your aerobic capacity low? He turned out he had a stress fracture in his foot, so he couldn't run on the treadmill, and that's why his aerobic capacity was low. But he was a really fit guy, 31 years old, looked good, passed the eye test. But on paper, he looked bad. Again, another guy with a family history of heart disease at a young age. We put him on the program, and I can show you this is essentially where he is today. I see him once a year now. That's all we do is we check on him once a year, and he's maintained his results for more than 10 years. Back in 2002, we didn't have an ability to test lipoproteins, so one of the things about is we had to estimate his lipoproteins, but we know where they are today. This is another guy. This is one of the first guys from the city of Reno. I think maybe it was the first guy from the city of Reno that we ever started working with. And he came into my office, and we put this quote up there. He called himself a dead man walking. And he had a lot of issues, okay. But we got a hold of him, and we put him through the program, and we got him eating right and exercising. And so this was in 2006. This is him essentially today. He's just like the other guy. I see him once a year. We update him, but he's maintained himself. We've still got some work to do on his blood pressure, but he's dramatically in much better shape now than he was before. No more dead man walking. That's it. Rob and I are going to be available here for some questions, and we welcome them. Thank you.
Maybe just there have been some questions about, what type of paleo diet, what type of, how low carb, all that sort of stuff. We don't do a one-size-fits-all approach. So not everybody in this room is the same. What we have are trained practitioners that interface with these people and figure out what they need. We have certain people, like Scott alluded to, that a very low carb approach is inappropriate for them. For their particular genetic makeup, we do something that looks a little bit more like Paleo-Mediterranean. So they might be a little higher carb, coming more from paleo-safe starches. We start thinking about small intestinal bacterial overgrowth, systemic inflammation. So it's not a one-size-fits-all approach. That's why we need highly trained people to interface with these folks and be able to customize things specific to their needs. But we use this overarching picture of evolutionary biology. We really get in and start tackling sleep, like we just did a gig with a very, very large international law firm, and 40% of the people in the law firm, 60% of the people in the law firm were on Ambien. lots of ambient. So you go on ambient and you don't have a normal sleep architecture, you don't have normal sleep architecture, you don't heal, you don't go into level 4 sleep, they're all inflamed. So even though we're like, we're always talking food, again, this evolutionary biology picture of like vitamin D levels, sleep, exercise, stress, community, this big overarching kind of holistic approach, that's what we need. You can't plug one hole and not expect all the other holes to ultimately drown you, just to give a little bit of big picture stuff on that. And then I'm sure folks have some probably specific questions.
Yeah, we've covered everything. That's really fantastic, Rob, that you guys are looking at sleep wellness. Are you doing home sleep studies, or are you ordering home sleep studies? That's huge.
So sleep studies, and this is a question for my pediatric dentist friends, so he understands some anatomy. To answer your question, no, I don't do sleep studies. What we do is we do a questionnaire. We refer people at high risk for sleep apnea for an appropriate sleep evaluation. But if it's an ambient problem, if it's one of the, trust me, I'm trying to get these people out of modern medicine and into, so I'm not trying to throw them onto the sleep doc. What we try to do is get them as far, control the variables that we can control, and then if we've got a significant medical issue, we'll refer.
Keep in mind, to refer for a sleep study, we know their sleep is broken. Like if they're metabolically broken, their sleep is broken. If they're a shift worker, it's broken. Largely what the sleep study validates is something for insurance.
If you order, right, exactly,
Yeah.
but you can order a sleep, it's only $250, and they're FDA approved, which
Right.
means nothing, but it's cheap, and they'll come and set it up in their home.
Right.
And then they can actually get referred to the right person.
Right.
So you guys,
This does raise a question though, so they start interfacing with the sleep doc, and this is why we're taking this thing and creating the City Zero project, which the basis of the project, we could implement this program on thousands, hundreds of thousands of people, process people, give a recommendation about what needs to be done, and then unfortunately we don't have physicians like are in this room or dietitians, they end up dropping the ball. And so then this amazing return on investment goes away because we don't have a network of people that can implement this in an appropriate way. So what we're working on is a soup to nuts program training coaches and trainers, allied healthcare providers, physicians, and researchers in this methodology so that when people need this, we have someone to send them to. And this also dovetails into the whole decentralized food network and the whole story. And honestly, the end game with this is to create a health insurance company built off of this structure so that then we use health savings accounts and all of the infrastructure based on this evolutionary template so that we can create an alternate track. Instead of going hat in hand, begging the establishment to let us in, we just create our own thing, which is much more profitable and actually works.
Carol Edwards, what we're setting up for the next talk is going to lead a little movement exercise.